everyone. I am Luciano Nerdo. I'm a consultant gynecologist and fertility specialist, the founder of NOW-fertility. I have great pleasure tonight to be joined by Dr. Ramon Orel, who will discuss the topic of how to tailor an egg donation cycle. Ramon is a UK trained obstetrician and gynecologist and has extensive experience in the field of assisted conception. He's the medical director of the fertility campus Quirón Salud in Barcelona. Good evening, Ramon, and thanks for joining me tonight. Ramon, how do you intend to tailor a egg donation cycle whenever you see your patients? What do you tell your patients?
Okay, when the patient comes to me, to my clinic for an egg donation, normally are patients that have failed maybe IVF before, or patients that are premature ovarian failure, patients that don't have regular cycles, or the ovarian reserve is very low, or they failed egg donation in other centers. So the first thing I have to do to select the best treatment option for them is to make sure I get it right at the first time. So the first consultation is very important. The history of the women, if she's alone or with a couple or partner, personal, of course, background, past medical history, like endometriosis, diabetes, blood pressure, or anything else. Of course, obstetric history is very important if they've been pregnant before, successful or with miscarriages, ectopic pregnancies, or premature labor, or prenatal death, or whatever they have. So all this is very important to make sure that you are giving the patient the most safety and security and option of pregnancy with the egg donation program of cycles. When a patient comes for egg donation, there's a second thing that's very important. Once you know the patient conditions, what the patient's needs, or what the patient wants, is basically to understand the pressure they have. Even if they have ovarian failure, even if they have IVF failures before, or what's more important, the age of that patient. But we believe that biologically speaking, a woman seems to be fertile up to the age of 50 because she's menstruating, so she's ovulating. So we believe that that age should be really a limit for assisted conception or egg donation cycle in our country, in our legislation. So age is also important. We have to bear in mind as well that the majority of the patients that come to us for like this last chance, they want to get pregnant on the first go. They want to get pregnant. Majority of them, they prefer to have two at a time. So the twins aspect here is also very important. We try to understand that because success rate in our egg donations programs in Europe, well, worldwide, are so high. With one embryo, we should get nearly the same results of transferring two embryos. So multiple pregnancy in egg donation should be avoided. And I do work with a lot of UK colleagues that I see patients in Spain, and the recommendation strongly is to go for one embryo transfer on day 5 in every recipient. The only time, or the only, difference here may be if the patient had only 2 embryos for transfer of not top quality rate, you may consider transfer 2, because you know that the chances of twin implanting is going to be very, very low. So that's something that we can discuss later, but twin pregnancy, again, is very important.
I just want to ask you another question. What are the facts, based on the indications and what you just described as being the patient's characteristics coming to the clinic, what are the factors that affect success rate?
I mean, the first thing, of course, is the past ART obstetric history. Any patient that comes to you with a failed IVF before with a partner, so they never success getting pregnant naturally or through IVF, If they are, of course, 47, 48, you understand that very well. But if they are between 40 and 45, then that's something that you have to be very careful, especially if they have implantation failures before, especially, and it's very important, never forget the male factor. If it's an heterosexual couple, we always have to remember that men counts as well. So it's very important. We look at the history of that woman. We look at the failure of IVFs before. We look, of course, at her stature, her weight, any medical conditions that she may have, but you have always to remember the male factor. So it's something that we really, really strongly look on that patient before we decide to embark on an egg donation cycle. Because to fail on that, if you have 3 or 4 or 5 IVF cycles with your partner, come for an egg donation cycle, and there is failed fertilization or no embryos of good quality, you say, well, I should have looked at this before. So that's something very important to check.
So I think what you're saying, that it is important not to forget the male partner when it comes to an egg donation cycle. And that, again, is something that sometimes is overlooked because we are only thinking about the patient or the couple coming for egg donation and forgetting about the other important component, which is the male partner.
Absolutely.
And what tests would you recommend for the male partner prior to being referred to you for egg donation?
Right. All the male factors that enter our clinics, again, the same as the female, they have a good male history. And if there's any andrological or male problem, they will see the andrologist as well in our clinic, so the same day. The first thing we do is the sperm analysis. Although we have maybe information from sperm analysis before, we do one in our unit, and we always evaluate that, and we freeze that sample in case, they cannot come for the egg donation day. So I have the male part frozen. We always ask to have the karyotype, the genetic test in the male. It's something that sometimes from people coming from abroad, it's never been done in the male and the female. So we always like to do a karyotype in the male. That basically will tell you if you're a man with all your genetic formula normal, same as a female. So it's something that we always do. And as I said, if you need to do anything more, like maybe a fish, chromosomal status in the spermatozoa, in the ejaculated, the andrologist will ask for that. And normally, we just do a spermiogram and karyotype. It's very good if we possibly have all the embryo quality and cycles that they felt before, and then the embryologist can check on that, because sometimes it's very evident. You can have a normal sperm in a male coming from 4-fail IVF, bad fertilization, very poor quality embryos, and that has to warn you that maybe a male factor. That's when sometimes andrology will recommend to do an egg donation cycle with pre-implantation genetic testing to make sure that the embryos that we transfer are genetically normal. Another thing that we always do, and something that is maybe new for a lot of patients, is the perfect matching. What means a perfect matching? Imagine me and my wife, we were married 35 years ago, we have 3 kids, we never worried about anything. Nowadays, I think if you go for an external gamete, the egg as an external one in the couple, we do what's called the genetic match between the man and the egg donor. So we make sure that the embryos that we have, they are not potentially having any rare disease. Remember that all of us have abnormal genes. If our couple has the same abnormal gene, 25% of our kids may have one of these rare diseases. So we check more than 3,000 genes between the male partner and the egg donor, and we do a perfect match to make it even more secure that the embryo has not, potential known genetic problems in the offspring.
Perfect. Thank you very much. How do you assess the female partner who may come for egg donation and she has had repeated failed cycles after good quality embryos being transferred?
Okay, here is very important the age of the failure. As you know very well, every woman over the age of 38 will have more than 50% of the embryos genetically abnormal. So if those IVF good quality embryos were below 38, I'll be very concerned. If the woman has 38, 39, 40, 41 and fail at IVF with their own eggs with no pre-implantation genetic testing, I won't be that worried because I still believe that euploidy, so normal genetically speaking embryos, after the age of 40 are so important to get success rate. So if I have a younger 34, 35-year-old woman with 4 or 5 good embryos, failed implantation, and she's not doing IVF anymore because she has a low ovarian reserve for whatever reasons, and she goes into IVF, then I will try to understand if there's any implantation failure affecting that. I keep telling my patients, I'm sure you agree with me, that 80% responsible of implantation failure is the embryo. So if I assume, because she's below 35, that their embryos were A quality, very good quality, sorry, and well, euploid, majority of them, then I will have to concentrate on the woman herself, like any uterine abnormalities, maybe a hysteroscopy will be very good as diagnosing polyps, septum, or quartus uterus, any other malformation, myomas that affect the cavity. And of course, I do all the thrombophilia study with my hematological team. I know this is very controversial. I know there is no scientific evidence, but before I go for a transfer, I have to make sure that I have all that control. And in that young couple that had failed IVF failures and with a normal sperm, I will always recommend egg donation with pre-implantation genetic tests to guarantee that the embryo I'm transferring, more than 80% of the chances will have no chances of failure. Different ways when I have a 41, 42, 43-year-old women that had 2, 3 failed IVF, top quality embryos, but no pre-implantation genetic test. Then I think I personally won't be that worried on the on that failure, because I would assume that these 3 or 4 embryos that were transferred at the age 41, 42, 43, own eggs were genetically abnormal. So I go straight, unless, of course, if there is no male factor, for a first fresh or frozen egg donation cycle. So I think age here is very important. That's my recommendation.
I absolutely agree. Thank you. So I think what we can say that both partners have to be fully investigated, despite being referred for egg donation. So the male and the female partner require a suite of tests in order to maximize the chance of success. Although the primary reason for coming to see you is egg donation. So I think that message has come out very clear, and I'm sure that will be of benefit to many patients. Let's move on from investigation and tailoring the treatment. What are the chances of success of an IVF cycle using donor eggs in your practice?
Here I really like to, for the patients, or potential patients, to understand what's called the cumulative pregnancy rates. I think we have to be able today, with the technology we have in the IVF laboratory, with the abilities we have to go to embryo 5 transfer, with the time-lapse incubator. So really, with the EVA test that can help you to select the best embryo for transfer. If you have 3, 4, or 5 blastocysts on the egg donation cycle on day 5, I want my patients to understand that over 80% of those patients will get pregnant. Maybe they may need 1 transfer, 2 or 3, but I think it's very frustrating when you come for an egg donation cycle and you believe that transfer is going to get you pregnant. It's very important to understand that for transfer, we cannot give patients more than the 62% pregnancy rate. Remember, that's pregnancy rate, that's not live birth rate. So once the patient understands that majority of the patients coming to egg donation will get pregnant, understanding that they may need 1 or 2 or 3 embryo transfers, then I think they probably will agree that majority of them will get pregnant. So it's important for them to understand that we donors are not, remember, a donor may be a donor that's been pregnant herself, a donor that we used before for another couple, so the recipient got pregnant. So there's not 100% biological mathematical equation. You may have a very good young egg donor with good sperm, and then you may get a bad cycle after that. So I really like in the first consultation, they see also my embryologists, and I want them to understand the way the IVF laboratory works, the way the embryos are cultured, the way the traceability of the embryos. But again, that's not 100% success rate, and that could be very frustrating for them.
You mentioned about cumulative pregnancy rate,
yes,
which clearly comes from a number of available blastocysts that can be transferred.
Yes.
What is the average number of blastocysts that you achieved in your laboratory?
I mean, we do have, and it's very interesting, Luciano, two sorts of egg donation. What's called a full egg donation cycle or a mini egg donation cycle. And you understand why we do this. We calculated in our laboratory many years ago that we needed between 3 and 4 mature eggs to get a good blastocyst for transfer. So said that, if I have a patient that comes to me at 48, 49, they only will have one baby. I prefer them to go for the mini egg donation because I know I would guarantee a good blastocyst for transfer with a 55, 65% pregnancy rate. If they don't get pregnant, I prefer to change the donor and do a new batch of 3 or 4 mature eggs. If we go for a full egg donation cycle, that means that I have to guarantee minimum 8 mature eggs. So if I guarantee 8 mature eggs, normally 8 will be the minimum. They may have 10, 12, 14, 15. Although I don't recommend them to have more than 12, because the last thing you want to this couple is to have 5 blastocysts, and then when they become 50, they have to make the decision, what do I do with these blastocysts? Do I give them to somebody else? Do I destroy them, or I give them for research? So I think here it's important for the patient to understand that it doesn't mean that if you have 20 eggs, your success rate will be more. If you have 8 or 10 mature eggs, we guarantee between 2 and 4 blastocysts, good blastocysts for transfer. It means that probably in these 3 or 4 embryo transfers, more than 80% of those ladies will get pregnant. So I think the efficacy in our IVF laboratory, thanks for having a very good IVF embryologist and a very good technology from incubators, EVA test, etc., gives you the capacity to tell them that, listen, 3 or 4 mature eggs, I will guarantee you a good blastocyst. And if not, no problem. As I said to them always in the first consultation, that's not a 100% biological equation. If that donor hasn't enough eggs for them, we cancel the whole thing and we restart the synchronization again. The good thing about Spain, and you probably know, the legislation is good because the anonymity is still here. So we have a lot of egg donors coming through. And now that we are part of the Eugene group, our egg donation program is so big in Barcelona. So we don't have any problems having one donor cancel next month, I have another donor for you with all the matching characteristics, etc., etc.
Thank you. And the last question, which is probably one that is asked by patients many times, is how long does it take from when they decide to start the egg donation journey up to the time when they have an embryo transfer?
Okay, the way we do it, well, with the COVID, of course, we did a lot of online consultations. So once we are happy and ready to start, we'll start asking all these blood tests, the phenotype profile. This is a chart that the recipient will, eye color, stature, weight, a photo of both of them, family, babies, whatever, so to have more information. Normally, it takes between 2 or 3 months. It never takes more than that, unless we have a very strange is not the word, sorry, peculiar phenotype. We may have Black ladies. We're not that bad because we have a large Black community living in south of Barcelona. Blonde blue-eyed, sometimes it may take a bit longer because it's not typically Spanish. But those cases won't take more than, maybe 2 more months. So between 2 and 4 months, we may get these patients on track.
So between 8 and 16 weeks.
Absolutely. And remember what we are doing now, since the COVID, and it's working beautifully, it's all frozen embryo cycle. So if I have the couple that's visited here, we have all the matching tests done, we have the sperm analysis frozen. And imagine next week, I have a donor that gives me more eggs. So I will contact them, tell them, listen, we have a donor coming for egg donation tomorrow, has probably 8 or 10 sperm eggs that could be for you. So we inform them and we create the embryos, freeze the embryos, and then do transfer on her next period. So it's quite fast and quite very well organized. Remember, we've been doing egg donation for the last 20 years, and we are doing 70% of the egg donation cycles in Europe, in Spain. So we are very happy to work the way we do it, and we are quite familiar with that way of working, of course.
Okay, Ramon, thank you for answering all these questions for the benefit of our patient population.
Thank you, Luciano.
Thank you very much indeed. Thank you, Ramon. Thanks for contributing to this very useful and informative session.